You know that feeling, right? You're staring at a huge pile of articles, maybe some dense research, and you just sigh. Information overload. You know there's gold in there, crucial insights, but actually getting to them, understanding them, it feels like climbing a mountain. Well, that's what we love doing, tackling those mountains and finding the clearest path for you. Today, we're diving into something that sounds pretty intense. Lateral sinus thrombophlebitis.
It does sound intense, yeah. And the material we're working from, it's medical excerpts. So dense, definitely written for doctors, but absolutely packed with vital information. Our job really is to translate that, make it clear for you.
Exactly. We want to unpack this whole condition, make it understandable, pull out the really key details, and connect the dots so you get the full picture without drowning in jargon. Think of it as your shortcut to getting clued in. Okay, so let's get started. Lateral sinus thrombophlebitis. Give us the quick version. What exactly is it?
Okay, simplest terms, it's an inflammation. Specifically, the inner wall of one of these big veins in your head, a lateral venous sinus, and that inflammation then causes a blood clot to form right inside that sinus. That clot's called an intrasinus thrombus.
And these lateral venous sinuses, they're important.
Oh, absolutely critical. They're major channels inside your skull. Their job is draining blood away from your brain. So, yeah, a very key area.
Okay, now here's something that really jumped out at me from the source material. This condition, lateral sinus thrombophlebitis, it doesn't usually just happen on its own.
That's a really crucial point. You're right.
It's almost always described as a complication, a really serious one, stemming from things many people might think of as, well, just a bad ear infection.
Exactly. We're talking things like acute coalescent mastoiditis, that's a severe infection of the bone behind the ear, or mask mastoiditis, which is trickier, or even chronic middle ear infections, especially if there's something called a cholesteatoma involved.
So the problem often starts somewhere seemingly much smaller, like the ear, and then escalates dangerously.
Spot on. It's a progression, which is why catching those underlying ear issues is so important.
Right. So it's a process, not an instant thing. It sounds like it develops in stages. Can you walk us through that? What's stage one?
Okay, stage one is the formation of a perisinus abscess. Perint meaning around or outside. So this is an abscess, a collection of pus forming right outside the sinus's outer wall. That wall is called the dura. It's a tough membrane covering the brain and these sinuses.
How does the infection get there?
Well, often that severe ear infection or the cholesteatoma we mentioned, which is like a destructive skin cyst in the ear, can actually eat away at the bone. That erosion lets the infection spread right up against the sinus wall. Interestingly, though, sometimes the bone itself is still intact, but the abscess forms anyway right underneath it.
Okay, so the abscess is outside the sinus wall. Does it just stay there? Or what happens next? What's stage two?
Yeah, it rarely stays contained like that for long. Stage two is where things get significantly more dangerous. It's called endophlebitis and mural thrombus formation.
Endophlebitis.
Yeah.
Inside the vein inflammation.
Exactly. The inflammation, the infection, basically breaches that outer dural wall and gets inside the sinus itself, inflaming the inner lining. And that inflammation inside the vessel wall triggers the formation of that blood clot, the thrombus, which starts sticking to the wall, inside the lumen, the channel of the sinus.
Okay, that sounds bad. A clot forming inside a major drainage vein for the brain. What's the biggest risk once that clot, that thrombus, is there? It's not just blocking flow, is it?
No, it's much worse than just a blockage. The huge danger here is something called septic disintegration.
Septic disintegration.
Yeah, think of the clot itself being infected. It can start to break down, decay almost. And as it disintegrates, it releases these tiny infected pieces, we call them septic emboli, directly into the bloodstream.
Ah, okay. And that leads to?
That leads directly to septicemia, blood poisoning, a massive systemic infection throughout the body. That's often life-threatening.
Wow, okay. And this clot, once it forms, I assume it doesn't just stay put either. Can it grow or spread?
It absolutely can. It can extend. It can spread proximally, meaning sort of upstream, further into the brain's venous drainage system. Think areas like the superior sagittal sinus, which runs along the top of the head, or the cavernous sinus near the eyes.
Any other way?
And distally, downstream, it can spread down into the big veins in the neck, like the internal jugular vein or the jugular bulb right at the base of the skull.
So we've got the process, the stages.
Yeah.
But what are the actual microbes doing the damage here? Let's talk bacteria. Who are the usual suspects?
Right. The bacteriology, the most common ones are probably familiar names. Hemolytic streptococcus, pneumococcus, and staphylococcus. Pretty standard bacteria, really. But especially if it's linked to that cholesteatoma thing or a really chronic, long-standing infection, you might find others. Things like Proteus, Pseudomonas, Pausanias, E. coli, yes, that E. coli, and even sometimes Mycobacterium.
Okay, got it. So, shifting gears a bit, for someone going through this, what does it actually feel like? How does this show up? What are the clinical signs doctors look for?
Well, one of the most classic, almost textbook signs is this really dramatic fever pattern. It's called a picket fence type of fever with rigors.
Picket fence, like up and down.
Exactly like that. Sharp spikes in temperature, then suddenly drops back down, then spikes again. It's very intermittent. And those spikes, they often happen right when those septic emboli, those infected clot fragments, break off and enter the bloodstream.
Oh, okay.
And these fever spikes are usually accompanied by really severe chills, the rigors, and then drenching sweats as the fever breaks. Overall, the patient usually looks quite unwell, often has no appetite, maybe irregular bowel habits too, just generally feeling very sick.
What about headache? Is
Yeah.
that common?
Yes, headache is often an early symptom. Initially, it's probably due to that perisinus abscess, the inflammation right outside the sinus. But as things progress, especially if the thrombus causes venous obstruction and pressure builds up inside the head, that headache can get much, much worse.
The source material also mentioned progressive anemia and emaciation, like a wasting away.
Yeah, that's tied to the chronic infection, the long-term suppuration, the pus formation. It particularly relates to inflammation affecting the mastoid emissary vein, which connects veins inside and outside the skull near the ear. It just contributes to this overall decline in health, this wasting.
And then there's something called papilledema. Can you break that down? Does it mean vision problems right away?
Papilledema basically means swelling of the optic disc. That's the spot at the back of your eye where the optic nerve connects. Whether it shows up often depends on how far that thrombus has spread, especially if it gets into that superior sagittal sinus we mentioned earlier.
So it's a sign of increased pressure.
Exactly. You might see swollen veins or even little hemorrhages on the retina when looking into the eye. But interestingly, and maybe counterintuitively, a person's actual vision can often remain surprisingly good, at least initially, even with papilledema present.
Okay, so someone presents with these kinds of symptoms, the picket fence fever, the headache.
Yeah.
How do doctors confirm it's actually lateral sinus thrombophlebitis? What investigations do they do?
Right. Diagnosis needs several pieces. Blood tests are absolutely key to start. A hemogram, or complete blood count, usually shows anemia, like we talked about, and definitely a raised white blood cell count the leukocytes signaling infection.
Makes sense.
They'll also do a blood smear, partly to rule out other things that can cause weird fevers, like malaria, believe it or not.
Really? Malaria.
Yeah. The fever patterns can sometimes look superficially similar, but the most critical blood test is the blood culture. This is how you actually identify the specific bacteria causing the whole mess. And because the bacteria might only be released into the blood intermittently during those fever spikes, they often need to take several samples over time to catch them.
Okay, blood tests are crucial, but I imagine imaging plays a huge role here, looking inside the head. What are they looking for on scans? Is there like a telltale sign?
Oh, imaging is fundamental, absolutely. Different scans give different pieces of the puzzle. A high-resolution CT scan of the temporal bone, that's the bone around the ear, is great for seeing if the mastoid air cells are clouded, showing that initial infection source.
Oh.
Then there's a CECT scan, which means contrast-enhanced CT. This is where you might see that telltale sign you asked about, the delta sign.
The delta sign. Okay, what is that?
It literally looks like a triangle, like the Greek letter delta. It's an empty-looking triangle within the enhancing sinus wall on the scan, usually seen in the posterior part of the skull. It represents the thrombus itself, surrounded by the contrast, highlighting the inflamed sinus walls. So yes, a really key visual clue.
Fascinating. Are there other scans, too?
Yes. MR angiography, or MRA, is actually even better sometimes for clearly outlining the thrombus itself and even assessing how fast or slow blood is flowing or not flowing in the sinuses. It gives a more dynamic picture. And MR venography, MRV, is specifically designed to look at the veins. It's really useful for tracking the thrombus over time, seeing if it's getting bigger, smaller, or resolving with treatment.
Any other tests? What about spinal fluid?
Yeah, a CSF examination testing the cerebrospinal fluid via a lumbar puncture might be done. Usually, the CSF itself is normal in this condition. However, if the infection spreads to cause meningitis and inflammation of the brain's coverings, then you might see changes, like a rise in protein levels in the CSF.
And one last thing. Seems obvious given the connection to ear infections.
Absolutely. If there's any discharge, any pus draining from the ear, getting a sample for culture and sensitivity is vital. It directly tells you what bacteria are present in the likely source infection, and really importantly, which antibiotics are going to kill them.
Okay, so you identify it. But given everything we've heard about septic emboli and spreading clots,
Yeah.
what are the really scary outcomes doctors are trying to head off? What are the major complications?
Yeah, the complications are why this is taken so seriously. The biggest, most immediate threat is that generalized septicemia, the blood poisoning. It can rapidly lead to shock and organ failure. It's a true medical emergency.
Right.
Beyond that, those septic emboli can travel anywhere. They can cause abscesses, collections of pus in distant parts of the body, the lungs, bones, even the brain itself, or just under the skin.
Wow.
Locally, the infection can easily spread to cause meningitis, infecting the brain linings, or subdural abscesses, pus collecting just under the dura. There's also a risk of a jugular fistula, which is an abnormal connection forming involving the jugular vein.
And the thrombosis itself spreading.
Yes. If the thrombosis extends down into the jugular bulb and the main internal jugular vein, it can actually affect the cranial nerves that pass right nearby, specifically nerves 9, 10, and 11. That can impact swallowing, your voice, even moving your shoulder.
But that sounds debilitating.
It can be. And if it spreads the other way, into the cavernous sinus, this network of veins behind the eyes that causes very specific alarming eye symptoms. Things like chemosis, which is severe swelling of the eye surface, proptosis, where the eyeball bulges forward, the eye might become fixed, unable to move, and papilledema, that optic disc swelling we discussed.
And one more.
Yes, if the clot extends way up into the superior sagittal sinus, it can block the normal drainage of cerebrospinal fluid, leading to a condition called otitic hydrocephalus, which is basically increased fluid pressure inside the brain originating from the ear problem. Also very serious.
Okay. The complications sound truly severe.
Yeah.
So let's talk treatment. What's the approach? How do you fight this?
The cornerstone, the first and most critical step, is aggressive intravenous antibacterial therapy. High doses, given directly into the vein. And the specific antibiotic choice, that depends entirely on what the blood cultures and any ear discharge cultures show. You need the right drug for the specific bug based on those sensitivity tests.
And it's not a short course, I assume.
Definitely not. It's intensive. And typically treatment needs to continue for at least a week after surgery, often longer, to make sure every last bit of infection is cleared.
Right. You mentioned surgery. That sounds like a key part. What does the mastoidectomy and exposure of sinus involve?
It is absolutely central to treatment. A mastoidectomy means surgically removing the infected mastoid bone cells behind the ear. This allows the surgeon to get right down to the dura covering the lateral sinus. Any perisinous abscess found outside the sinus is drained. Then the surgeon carefully makes an incision in the sinus wall itself.
Inside the sinus.
Yes, to remove the infected clot, the thrombus, or any pus inside the sinus. It's meticulously cleaned out. It's important, though, if they encounter healthy-looking red clot, they generally leave that alone, as disturbing it can cause more problems. After cleaning it out, the area is usually packed, often with antiseptic gauze, to control bleeding and allow drainage. That packing is typically removed after about 5 or 6 days, and then the wound is properly closed later.
Okay. The notes also mentioned ligation of the internal jugular vein, tying off that big neck vein. That sounds extreme. Is that common?
It sounds very extreme, and thankfully, it is very rarely needed these days with modern antibiotics and surgery. It's really reserved for very specific, difficult situations. Like if despite antibiotics and surgery, the patient is still throwing off septic emboli, still having those severe rigors, or if there's clear evidence of spreading infection down the jugular vein in the neck that isn't being controlled, only then might they consider it.
Got it. What about anticoagulant therapy? Blood thinners, you'd think with a clot.
You would think so, wouldn't you? But again, it's actually rarely required for this specific condition. The main exception might be if the thrombosis, the clot, has clearly extended into other major sinuses, like the cavernous sinus. In that specific situation, anticoagulants might be considered to try and prevent further clot propagation, but it's not routine.
Okay. So antibiotics, surgery, anything else? What about just general support for the patient?
Yes, supportive treatment is really important too. These patients are often very sick, very run down. So things like managing fever, ensuring good nutrition and hydration, and very commonly repeated blood transfusions. That anemia we talked about can be quite severe due to chronic infections, so transfusions help boost their blood count, their oxygen carrying capacity, and just generally improve their strength and ability to fight the infection.
Wow. Okay, what a journey through a really complex condition. We started with the definition inflammation and a clot in that lateral sinus. Then we saw how it's usually this dangerous complication, often starting from a serious ear infection. We traced the stages, the abscess outside, the inflammation inside, the dangerous clot forming and breaking apart.
Right, and then the bacteria involved, how it shows up with those dramatic fevers and headaches, the different tests needed for diagnosis, especially the imaging and cultures.
And the potential for really severe complications spreading through the body. And finally, the treatment focused on heavy-duty antibiotics and crucial surgery, with other measures used only in specific cases.
It really underscores how vital that prompt diagnosis and really comprehensive treatment are. Given the potential for things like septicemia, meningitis, brain abscesses, getting on top of it quickly and thoroughly makes all the difference.
Absolutely. And it's fascinating, isn't it, how digging deep into one specific, maybe seemingly obscure medical issue reveals so much about how interconnected everything in the body is, how a problem in the ear bone can threaten the brain and the whole system.
It really does.
So as we wrap up this deep dive, maybe something for you, our listener, to think about. What broader lessons can we take from understanding something like lateral sinus thrombophlebitis? What does it tell us about that constant battle inside us between infection, our own inflammatory responses, and our body's defenses? And maybe what does it teach us about the hidden dangers when infections we might consider common are left unchecked or aren't fully treated? Something to ponder.